Okay, we're ready to get started. Can everyone hear me okay? Great. So thank you so much everyone for being here tonight. Welcome. We're so happy that you are all here to learn more about OneCare Vermont, our accountable care organization, and how it all fits in with Brattleboro Memorial Hospital. So we thought it was really important to invite you all here tonight to share with you about what it means to be a part of an accountable care organization. Many of you may have received a letter in the mail saying that you are attributed life to BMH and that you are part of an accountable care organization, and you may have thought, what does that mean? I have no idea what an ACO stands for. I have absolutely no idea what it means to be an attributed life. Is this good? Is this bad? And so we thought it was important to invite you all here tonight to share with you exactly what that means and what that means for your healthcare. Both you as an individual patient, also healthcare for our community, and what it means for us as a hospital to be part of an accountable care organization. So our goal tonight is to share that with you and help make it really clear so that when you leave tonight and your friends say to you, what did you learn at this event? What does it mean to be part of an ACO? What are those letters? You can hopefully provide them with an answer that's clear and concise. So that's our goal tonight. So today we have a fun-filled agenda for you. We have a couple of different people here to help share information with you and help to present information on what it means to be part of an accountable care organization. You'll hear from Becky Burns, who's our Director of Community Initiatives and Director of the Community Health Team, and she's going to share with you what it means to be involved in care coordination. She's going to introduce you to our care coordinators who will be a part of your healthcare team. We'll also hear from Dr. Denise Pasha, who's a family medicine physician at Maplewood Family Practice. Maplewood celebrates their 18th anniversary today. Congratulations. 18 years of providing care in our community. So she'll share with you what it means to be involved in care coordination and how care coordinators impact her patients that she provides care to every day. She'll also share with you information on a group that we are a part of called the Accountable Communities for Health. And that's a group of community organizations who are involved in making improvements in the healthcare of our community as a whole. So you'll hear a little bit more about that. And then I said we'll have halftime, and we'll come back towards the end with time for questions and hopefully work to provide answers. So great, with that said, I'm gonna kick off with a short video that we created. Our marketing and development team worked hard to put together a fun video that hopefully helps describe what an ACO is. It's about a 2-minute video, and we're gonna do our best to make it very clear and concise what it means to be part of an ACO.
What if your healthcare was as easy as connecting dots? You want a clear picture, coordinated quality care that looks out for your best interests. We agree, and we're doing something about it. A lot of people in Vermont have chronic conditions that need attention and care from multiple clinicians. What if you saw one clinician about your condition, and they could coordinate tests, follow-up visits, prescriptions, labs, anything you needed, and you didn't have to make several phone calls or carry your medical records from one office to the next? Well, there's a new way to make that happen. It works like this. We link our clinicians, specialists, hospitals, and other healthcare service providers together to form an accountable care organization, ACO for short. They partner together to form your personalized team to focus on you and your unique healthcare needs. Your ACO makes sure all those people at all those places know exactly what everyone else is doing, what your treatment plan is, and what your health goal is. Everyone looking at the same test result means everyone is on the same page. No shopping around to find a doctor or specialist to provide the care you need. The legwork is already done. We even help schedule appointments to fit within your busy schedule and follow up phone calls to make sure your health is on the right track. And since everyone is working together, you're provided a clear and concise picture of all your healthcare needs. That means you're getting the best care possible. OneCare Vermont is forming these teams across the entire state of Vermont to meet your healthcare needs. So no matter where you are, we've got you covered. A personalized, simplified, and thoughtful approach to coordinating your care. OneCare Vermont and Brattleboro Memorial Hospital.
Great. So hopefully that helps to give an overview of what it means to be part of an accountable care organization and help set the stage for what we're going to share with you tonight. So the main objective of being part of an accountable care organization or an ACO is the triple aim for healthcare. And that involves 3 components. The first one is better care for individuals. So at an individual level, at each patient level, making sure that we are meeting your healthcare needs. We accomplish that through care coordination. We work to create care plans that involve your healthcare goals and work with you to help you meet those goals. It includes better care for our population, better care for our community, working to make improvements for our community as a whole. We do that through things like the Accountable Communities for Health, where we involve many different community partners in building the infrastructure to provide better care. We also do that through looking at patient satisfaction scores and making determinations of how we can improve your care based on feedback from our community. And lastly, the triple aim involves working to lower the cost of healthcare, working to lower costs for patients and for the hospital as a whole. So the first part of the triple aim is working to improve healthcare for individuals. As I mentioned, we do that through care coordinators. That's one of the many ways that we work to improve care for individuals. We do that through making care plans that are focused on your individual healthcare goals. Care coordinators will work with patients in the office, outside of the office, to work to meet those goals. And then the Accountable Care Organization, ours is OneCare Vermont, works to hold the hospital accountable for working to improve healthcare goals by providing us with a scorecard or a report card per se. To help simplify it, they will give us scores or a grade on how we're doing on very specific quality measures. We have 33 quality measures that we work with OneCare to make improvements on. These include things like making sure you have your flu shot, making sure that you have a mammogram if you're of that certain age, making sure you have colorectal screening, making sure you're coming in on a regular and routine basis for your wellness visits, your physical exams. And OneCare provides feedback to us on how we're doing, and we work to make improvements based on that. It involves working to lower the cost for you as a patient and for us as a hospital. And one of the key ways that we partner with OneCare to lower the cost of healthcare is a focus on prevention. It's really important to get you to see your primary care clinician on a regular basis for your physical exam, for your wellness exam, and at those visits there's a focus on the screening tests that you need, such as the ones I mentioned earlier, mammograms, colorectal screenings, making sure you're getting your immunizations, a focus on keeping you well, a focus on keeping you out of the emergency department. And one of the more innovative programs that we are partnering with OneCare on is the 3-day skilled nursing home waiver. And that allows us to, for patients who qualify and who are medically stable, if they are in need of a rehabilitative stay at a skilled nursing facility, the 3-day inpatient stay is waived. And that allows patients to get the right care at the right time in the right place. And lastly, working to improve care for the population. And one of the ways that we can work to achieve that is through looking at our patient experience scores and looking at your feedback on how we can make improvements to the healthcare system as a whole. Many of you may receive surveys from us. You may receive multiple surveys from us. We send surveys through the National Research Corporation and also through the Blueprint for Health. Those surveys ask you questions about the care that you received at your visit, at a lab visit, at a x-ray that you received, kind of many different touch points in the hospital. We'll ask you for your feedback. And we use that feedback to make improvements in our healthcare. That feedback, we can also compare it to other local hospitals, and we can compare our scores to see how we're doing compared to other hospitals. And from there, we can collaborate with those hospitals on improving your healthcare. So it does involve and allow us to have an opportunity to partner and collaborate. And we've made some tangible changes based on patient feedback and on our patient satisfaction scores. One of the main things is the care coordinators, which you're going to hear more about today, and having a dedicated nurse assist you with your healthcare needs. The second thing is offering extended hours through our primary care practices. We offer evening hours at several of our primary care practices currently to help allow for more flexible options for patients to receive their health care. So with that said, I'm going to turn it over to my colleague, Becky Burns, who's the Director of Community Initiatives and the Community Health Team, as well as Corey Prapal, who is with OneCare, and Corey is the Manager of Clinical Programs.
As Ailey mentioned, I am the Director of Community Initiatives for Brattleboro Memorial Hospital, and I also work for the Blueprint for Health for the Brattleboro Health Service area. So what I'm going to focus on is talking a little bit about care coordination. You also might have heard care management in the past if you were ever in the hospital. Those terms are used interchangeably. So care coordination is really focused on the patient. The patient receiving the right care at the right time and collaborating with partners to make sure that the transitions of care, moving from primary care to a specialist, is seamless for the patient. It involves multiple agencies. They could be within the hospital, cardiology or orthopedics. They could also be at Dartmouth or UVM or over at Cheshire. The goal of care coordination is to have primary care be sort of the hub of your information to help navigate that system. If you choose a different hub, that is completely up to you, but primary care is definitely able and willing to do that with the addition of the new care coordinators that have been hired into the primary care practices to do this type of work. Communication is the ultimate goal of care coordination. Care coordination has really been going on for a very long time. In the hospital with care management, if you were admitted as an inpatient, care management would work for your discharge plan to set you up with services at home. The community health team has been doing care coordination for a very long time, and we are very excited to have it happening now with dedicated staff in the practices to be able to do that. We wanted to talk and give a story example. Names have been changed for this, but Tom's story is an example of why care coordination is important. Tom is a male patient in his 40s. He is assigned to a very high risk category. He's noted with primary care as being at risk, and outreach starts for Tom in June of 2017. And Tom decides to engage in care coordination in September of 2017. In doing so, Tom received more personalized care. He currently sees his primary care physician, he has a specialist in cardiology, and he also has a mental health care practitioner. He has several chronic conditions, including schizophrenia, coronary artery disease, and hypertension that isn't well controlled. As a result from engagement, his visits to the emergency department were decreased. He felt that there was no need to go to the emergency department now. He was getting what he needed at his primary care office. So in 2016, he had 6 visits, and 0 in 2017 to the emergency room. His primary care physician visits increased from 0 in 2016 to 5 in 2017. A direct correlation to being re-engaged with primary care, working with care coordination, and having his needs met and not needing to go to the emergency room. The total healthcare costs were decreased by 60% by avoiding the emergency room and working with his primary care providers and the team at the primary care office. There is also a population approach to care coordination. So OneCare reviews everybody's status, their claims, and assigns them a risk score. So with that risk score, it helps identify who's at greatest risk, who needs the most assistance possible. So there are a couple different quadrants that the population falls into, that all of you, as attributed patients, fall into. So 40% of the population is really focused on preventative care. These are the patients that are currently listed as healthy, not requiring a lot of assistance, no chronic conditions, and receiving preventative care, seeing their doctors regularly. The second category is the medium risk. The medium risk has the potential onset of chronic disease. They have risk factors, and so they are placed in a medium risk category. Category 3 is high risk. High risk has multiple chronic conditions and co-occurring social needs, meaning there's a potential for housing insecurity. There's a potential for food insecurity. And 6% of the population, this is our smallest sector of the population, is the very high risk. The very high risk patients have several challenges and severely complex medical needs. Those patients are the ones that are at greatest risk right now and not having all of their needs met. The hospital receives a list, and we're able to outreach to the patients that need us. Patients can also enter care coordination if they are designated by their primary care provider as needing it. You don't have to be attributed to get care coordination. That is across the board.
I'm just going to give a few more details to this slide. So what Becky's saying, this top, your left corner, for the healthy population. So when we're looking at that category, for the long term, for this to work, we need to keep people healthy. We want to prevent them from getting down here. And so what that means is coming into your primary care, having those screenings, even for children, having them come in for well child visits, developmental screenings. We want to identify things earlier so that we can get the help and the intervention before it becomes an issue. So we're here, and what Becky's saying, so early or newly diagnosed chronic conditions, diabetes, high blood pressure. So again, we gotcha, we have identified it, so now how can we help get to this next category? That's helping you manage your condition, going to your primary, going to your specialist, giving you the tools that you need in between those visits to stay as healthy as possible, whether that's testing your blood sugars, glucose logs, helping you quit smoking. So those are really some of the interventions. So just so you can kind of see what these quadrants might look like in everyday life, that's what we're looking at. And Becky's really focusing on the care coordination piece, I think, next. And this is very important, but just to kind of understand these top slides as well, I just want to add that.
So I'd like to just introduce some of the care coordinators that we have present tonight that work at BMH. So if you can direct your attention to the back of the room, I will introduce them. We have quite a few partner agencies right now that we are working with. BMH, the Community Health Team, SASH, which is Support and Services at Home, and Senior Solutions, HCRS, Beata, and VNA. I mentioned Brattleboro Primary Care, Laura is representing them, OneCare, and the Blueprint. So these are organizations that have been engaged heavily with care coordination, have been attending the trainings, and we're really happy to have them on our team and have them on your team. So the organizations that we're working with in the community, what I just spoke about was really patient-centered, and the community piece, we have a lot of partners in the community, a lot of organizations that we are working with to help patients obtain the best care possible. The organizations that we work with, we really focus on changing the system, changing how communication occurs across agency, making it easier for patients to navigate the healthcare system and work really hard at prevention and keeping people healthy. So at this point, I'm going to hand it off to Dr. Pasha.
So I was just going to give you a brief information on what this looks like, first of all, from our office. It's been a really exciting transition for us, really turned us from sort of a small practice that could just focus on specific health problems of each individual patient to teamwork. It's allowed us to broaden our definition of healthcare to include many of the social determinants of health and really work with our care coordinator to help people access the broader community and things they need in their health. So a couple of examples of this would be, for instance, I had a patient the other day who was really having a significant mental health crisis. In a primary care office, I can offer support and counseling, comfort that one time, but I was able to call my care coordinator, Colleen Fisk, into the room to meet with the patient to help organize a psychiatry appointment, a counselor, to talk about whether inpatient was available that day for her, and to really spend some time expanding beyond our office into how this patient would re-enter the community and what kind of support would be there for her. So that kind of availability is really, I think, made that appointment much more beneficial for the patient than just an individual talk with myself. Other ways we've used it, for instance, in patients who are unable to get proper food or healthy food, we now have a lot of resources we can offer on how to find those things in the community. And if we think patients are going to have trouble navigating that themselves, then the care coordinator can follow up with them, make sure that they've been able to take action on the information that we gave them in the office visit. I've also had help with entire families. The care coordinator can reach out to multiple family members, make sure an older patient is safe at home, make sure that if they need some adult day assistance, that's all happening. Things that it was very hard for me to juggle myself in the past, I can now routinely provide to patients. So that's been really nice, and I think really appreciated by our patients. In sort of a different vein, working with OneCare, we routinely get feedback on the medical care we provide. So for instance, I get told how many of my patients with diabetes are not well controlled. And then we can specifically call those patients and reach out to them and do more of the intervention and assistance they need to get their illnesses under control and to treat them more completely. Overall, in our office, we've become much more of a team effort, and that gives a lot more depth and help to patients. That it's not just that they have to track down the individual doctor, but they can talk to our care coordinator and to our nurses and get good information, and everything gets passed back to me. But they don't have to wait to get a call specifically from me. As you know, it can be really hard to track down an individual doctor. I also want to talk for a minute about this Accountable Communities for Health, which is a really exciting project for me. I've been working on it for a number of years now, and some of the lead-ups to it. It's a project that I get to go out of the office and be in the community, and it's enabled me to meet a lot of the different organizations in the community. Brattleboro is a very rich community for social services and for people who spend their lives helping other people and trying to make our community a healthier and better place. And we've taken on this actually is a new organization that's just been meeting in its current form for the past, 4 months or so, 3 or 4 months. But some of the things we've been able to do leading up to this is a way of creating projects that benefit the whole community. So for instance, based on data we had from our labor floor of an increasing number of infants born affected by substances at our hospital, we were able to create a project that involved many of the organizations in town that touch the women's lives and the infants' lives. That would be For instance, the Retreat, Habit OpCo, which does methadone. We involved Winston Prouty, some of the family and infant services, DCF, the labor floor here, OBGYNs, pediatrics, to really try and help pregnant women with substance uses and make sure that they had healthy pregnancies, that they and their infants were well cared for. Just very exciting to start to see the labor floor nurses going to Habit OpCo and meeting women on methadone and introducing them to, what their delivery would be like, how their infant would need to be treated, and we are hoping that because of that we see not only fewer infants who are exposed to substances during pregnancy, but also more families staying together and healthier young people in our community. So it's that kind of project that we're working on that pulls in all different segments of social services in the Brattleboro and Southern Vermont area to try and really improve the health and well-being of everyone. And I'm happy to answer more questions about that. As the group gets going, I'm hoping that all of you will start seeing us out in the community and hopefully contribute and benefit from the types of projects that we'll be working on. Thank you.
You guys asked really excellent questions. You're pretty much stumped here, but we're gonna do our best to answer your questions. So thank you very much for being so engaged and really giving us such thoughtful questions. We really appreciate it. So we're gonna go down the list here. We're gonna read your question and do our best to provide an answer. So the first question says, are referrals needed to see a specialist, or can you make your own appointments? So that question, it does vary a little bit by insurance type. And so the safe bet is to if you were ever to wanting to make your own referral to see a specialist without getting a referral from your primary care clinician, the safest bet is to call your insurance company and to ask them if you need a referral. That's the safest way to go about it, to ensure that you're not on the hook for that payment. We will do our best. If you were to call a specialist to schedule an appointment, we would do our best to help you with that approach and help to see if you needed to have a referral, and we do our best to help get you that appointment as well as coordinate that referral if that was indeed necessary.
Hi. So my question has to do with age-appropriate tests. It says, stressing about as I get older, I don't want to be forced into screenings that I am not comfortable with. So this is a dilemma because when we look at population health, we're encouraged for everybody to get their proper screenings at the right time, and for a whole population, that ends up with the best outcomes, the healthiest people. However, I think every individual doctor knows in working with their patients that what goes for a population doesn't necessarily go for each individual. And so that would be your job with your primary care doctor to talk about each of the recommended tests and see if they are really things that you feel would benefit you individually. And what I do when I have patients who we decide that a test isn't good for that particular patient, I document in my chart that we've had that discussion so that if somebody's looking to see, oh, did she get, colon cancer screening on every patient, if they get to that patient, they'll say, oh, they had the discussion and that's fine. The patient and the doctor decided it was not appropriate in this case.
Hi, my question is, are the care coordinators medical people or administrative? So the care coordinators in the BMH practices are registered nurses for the most part. They are all clinical people, just so pediatrics. For our pediatric practice, Brian is an MA, so a medical assistant. So yes, they are clinical people, they are not administrative people.
Hi, thank you. So the question, how will OneCare maintain transparency for consumers? So we do this a few ways. One, if you go on to our website, onecarevermontbt.org, you can see that there are minutes and agendas from our meetings, from our board meetings and committees. So that's one way you can see some information. The other way, we do have to report our quality measures to the Green Mountain Care Board. Once the Green Mountain Care Board has reviewed those, they are on the Green Mountain Care website for public.
My name is Ailey Peterson. I'm the Vice President, Medical Group Management and Population Health here at the hospital. My name is on the agenda. It's the one that is spelled in a way that doesn't look like Ailey. So we can all thank my mother for that. So the next question that I have is kind of a three-part question. So someone was quite ambitious and put 3 in 1. Thank you. First question was, how was I chosen? So that question kind of gets to how am I attributed? How did I get to be attributed in OneCare? And I'll give you somewhat of a complicated answer, and then I'll give you the easy answer. So the complicated answer is that there is a very complex algorithm that goes into determining how patients get attributed. There's a lot of science behind it. It has to do with claims. It has to do with the number of times that you see a primary care clinician here at BMH, a specialist here at BMH. The simple answer is that the attributed patients are patients who have Medicaid, Medicare, or Blue Cross Blue Shield. And it's primarily based on your primary care clinician with other factors involved, like are you seeing a specialist here on a regular basis? Corey, do you have anything to add to that?
You're right on. And so again, part of the ACO, it's a voluntary group of network providers. So we don't make anyone join, no one has to join, so it's a voluntary group that comes together to be part of the ACO. So your providers have chosen to be part of the Accountable Care Organization. And then it's a very complex software algorithm that determines that attribution. We call it, the explanation, it's the 9-page, one-pager. Yeah.
That's right. So for the question that she just asked, she said, if I received a card in the mail, a letter in the mail, does that mean that I am attributed? Yes, that is what that means, yes. The second question here, which Corey sort of touched on, was how do I opt out if I choose to? So say you got the card in the mail, say you got the letter in the mail that says that you're an attributed patient. If you do not want to participate, you most definitely have that right to say, I do not want to be part of this accountable care organization. If you choose to do that, on that letter that you receive, there's information about how you can reach out to CMS, Center for Medicare, Medicaid, to let them know that you would like to have your name taken off the list and that you would not like to be attributed. So that is an option for you, yes. The last question here was, does Blue Cross Blue Shield follow the 3-day Medicare waiver that I spoke about earlier? And it does not. In order to qualify to have that 3-day inpatient stay waived, you have to be attributed and you need to have Medicare or Medicaid. Corey looks like she wants to add something.
To use the waiver, however, some insurances are different and don't have that mandatory 3-night stay that Medicare does. So Blue Cross Blue Shield might not even have that as a rule where they would even need the waiver.
So this is a comment, but I'll try and turn it into one that needs an answer. It says, I'm concerned about OneCare governing people to systematize healthcare. And I think that this speaks to a balance in healthcare, a balance between the science of medicine and the art of medicine. The science of medicine requires systematization, and so we can improve a lot of outcomes of basic diseases and illnesses in medicine by being systematic about it, by doing all the proper testing, by giving the proper recommendations. On the other hand, there's the art of medicine and the interaction between individuals, understanding each individual that happens with your primary care provider. It's getting the services that you need, it's being able to get to them. So that's this balance between the type of reaching out we're doing with care coordination and the community health team, which is very individualized, but then also really following some of the basic tenets of science and medicine that do help with disease management.
Are the care coordinators at practices not associated with BMH? So the answer to that is yes. Brattleboro Primary Care, which is not associated with BMH, does have care coordinators in both their pediatric and their adult side. Other organizations that I mentioned do have a level of care coordination, care management, social workers that they do employ. What I would suggest is to contact your office, whichever office you're speaking about, and ask if they have a care coordinator present.
Great. The next question is the population health approach based on Vermont, local, or national percentages, and are they all related to payment or how monies are allocated to the healthcare providers? So I believe that question is referring to that 4-quadrant slide, and you're gonna catch me here. I believe it's definitely at least state level. I don't know about national, so I'm gonna check on that. You've caught me. And related to payment, so OneCare does provide some extra funding to help support the practices and community partners for our high and very high risk patients to help support the care coordination. So in that way it does relate to how some monies are allocated.
So this next question says, the coordinators have to get paid. How does that happen and how is insurance involved? So a couple ways to answer that question. As Corey was slightly mentioning there, OneCare provides us a monthly stipend for care coordination. And that is based on how many care plans are that we've created, how many of our care coordinators are listed as the lead care coordinator, and when that happens, there's a small stipend that is provided to us on a monthly basis to help cover the cost of care coordination. It's a good question because care coordinators don't fall into the typical fee-for-service model that your clinician follows. When you see a clinician, they submit a claim to your insurance company and it gets paid. It doesn't work that way with care coordinators, and so OneCare recognizes that and is helping us as a hospital to provide for care coordination.
So I took this question just because I thought it was really interesting, so I'm gonna invite the rest of the panel to help me with it if they don't like my answer. So it says, since the aim is to reduce costs, what safeguards are in place to ensure that the most high-risk patients won't be overlooked because of the higher costs involved? And this has to do also with this idea of what we call cherry picking. If you know a patient might need a liver transplant, maybe you should just not take that patient under your care because they're going to be very expensive for the system. And so one of the things we're doing with the outreach and looking at our high-risk patients is sort of, putting our arms around them instead of pushing them off. And that hopefully will enable us to help people be able to step down from that high-risk place to a more stable healthcare place. So we're really trying to avoid some of those very high expense things because we're addressing patients earlier. Now, of course, all of them you can't avoid. I mean, you can end up with a huge healthcare bill after a car accident, which has nothing to do with any of the healthcare providers you interacted with. So then you're really talking about the ethics of healthcare, and that I think most people in healthcare feel a very deep responsibility to providing care for the people who need it the most.
Just to add on to Dr. Pasha's answer, the other thing I would say is in the earlier question about how do the care coordinators get paid, in OneCare supporting care coordination, they provide incentive payments for patients who are high risk and very high risk. That's how the model is set up right now. So that means that OneCare is also helping us stay focused on those patients who are most at risk. So to answer the question about how do we make sure that patients don't get overlooked, that's another way that OneCare is helping to support that in a focused approach to making sure that the high risk and very high risk patients have additional focus when it comes to care coordination.
So I'll add a little piece, oh, yes, go
I
ahead.
just have a question.
Yeah, absolutely.
I really love the idea that you coordinate people's care, and I see that you guys work very hard to do your job, and I understand all that, but I don't understand what OneCare itself is doing. Maybe you could explain that to us.
Yes, I will try to, give a few things that, so you see Brattleboro, you see the coordination of care with the community partners. So some of the things that OneCare is helping in this process is one, providing those incentive payments to help support the resources such as care coordinators. We're also building on the community health teams that already existed in all of the health service areas in Vermont. And so we're supplying, again, more resources, we're supplying training and education, free of charge, open to anyone, regardless of whether they're in OneCare or not. So that's home health, the designated agencies, anyone can come and have that training. So we're all looking at the same things, focused on patient-centered care. What's a care plan? What's a care conference? Trying to educate all levels of staff, from people who are working with patients, to the leaders, to executives. What is care coordination and why is it important? We are also providing the analytics for providers to say where, right, so where, they're doing well, where they need to improve, what do they want to look at, what are the things they want to work on, and how can we support them in that? A couple things, and so the clinical education. So we do have a clinical education department and a big network. We are in the entire state of Vermont, so we are trying to take lessons learned and successes from different communities and bring them to other communities and share that knowledge. What's working well? How did they do that? Let's bring it somewhere where they want to implement it, so that we are sharing across the state best practices, so that we're not having to reinvent the wheel every time a community wants to start a new project. And so just having that kind of network and the sharing is also another benefit of OneCare.
So basically what you're saying is it's an organizational program that you're selling as OneCare, that you loop in all the people who are in healthcare in the state of Vermont into an organizational monopoly.
I didn't use monopoly.
No, I did though.
But we are just trying to provide that, again, some of those services. And that's just a quick touch that, again, my department helps bring to OneCare, or to the communities.
The question that I had is, how does this coordinate with Current Hospitalist System? So I think that question, and if anybody wants to correct me who asked the question, please feel free. I think the question is, how does this interact with the care managers that are currently in the hospital? So care management in the hospital is doing the same thing that it has been doing, really planning discharges for patients that have been admitted after surgery, after an accident. They are also working in the emergency department, so patients that frequently come into the emergency department, working with them to find out why, what is the root of their frequent visits to the emergency department, and how can we help them. Again, it's wrapping our arms around those patients to assist in what they need. So care coordination is also being really integrated with outpatient, inpatient, and outpatient. There's more exposure across this organization right now. Everybody knows from our care coordination team who the inpatient care coordinators are. The inpatient care coordinators can pick up the phone and call Colleen at Maplewood and say, I have one of your patients who's discharging. This is what they're really going to need. Can you help them? And provides a warm handoff. So the relationships that are being built from inpatient to outpatient are growing. And it's really exciting. I hope that answered the question. If it didn't, please grab me after and we can talk about it. That's all yours?
Next question. I haven't seen much talk about insurance coverage. So to answer that question, your insurance coverage, Medicare, Medicaid, Blue Cross Blue Shield, does not change. Nothing about your insurance coverage changes as a result of us being part of OneCare, as a result of you being an attributed patient. to OneCare. None of that changes. Benefit plan doesn't change, copay doesn't change, it's applicable, no changes. Anything else, Corey, on that? Sure. One of the goals is to improve access. How will a ACO do this for people who are uninsured or underinsured? So the ACO OneCare is currently focused on patients who have Medicare, Medicaid, and Blue Cross Blue Shield. Their current focus is not on patients who are uninsured or underinsured. However, the hospital, BMH, that element is very important to us. If a patient comes to us who doesn't have insurance or is underinsured, meaning that perhaps their deductible is so high that they can't cover that cost, and therefore that's a barrier for them receiving care. That is very important to us at the hospital, and we can help in several different ways with that. One is that we have a community liaison. Her name is Jocelyn Smith. She works full-time, and she helps patients who don't have insurance apply for insurance. She's been very successful in getting patients insurance. It's one of the many great things about our state is that most people in this state qualify for some sort of program like Medicaid. In addition to that, we have sliding scale discount programs based on your income. We also have charity-free care based on income. So if your income falls below the federal poverty guideline, a certain percentage, and you qualify, you can receive free care. Lastly, the care coordinators in each of our practices, regardless if a patient is embedded or not, attributed or not, they can help connect patients with the right resource to help them get insurance or help them with a bill if they're not able to pay a bill, or if they're concerned about receiving services because they're concerned about the cost. These are the types of things that our care coordinators can help with.
Yeah, I wanted to add to that from a practice point of view, even though the care coordination program is partially funded through OneCare and the CHT, the community health team is funded by the Blueprint, they are open to all patients. So it's very important for us in practice that we not ever say to a patient, oh, you have the wrong insurance, or you don't have insurance, you can't use care coordination, or you can't go to the community health team. Those services are available to everybody for free as part of their health care.
This question, the title of the program includes the word payment. Is there a financial change aspect to the program as it affects me? And I guess, is payment, was it the title of tonight? I'm just kind of worried where that word payment came from. Okay, it is on the paper. So,
Lowering cost of care.
lowering cost of care. So, the payment change is to the provider providing the care. It is not to the patient. So there won't be a change of payment as it affects patients. If anything too, when you think about the waiver program that Ailey mentioned earlier, that 2-day, the 3-day stay in the hospital to be transferred to a skilled nursing facility. So currently, right now, Medicare requires that 3-day stay to cover a skilled nursing facility stay. If a patient does not need 3 days and they're discharged in 2 and then goes to a skilled nursing facility, they have to pay out of pocket for that. Where this waiver actually can prevent that, a patient having that kind of payment. So it does help the patient, but it definitely does not impact the patient in a negative way.
Yeah, I would just say too that Vermont's system is trying to work from a fee-for-service payment, so just insurances or the state paying the doctor for each time the patient is seen, to a payment system that just covers the entirety of the patient. So you would get a per patient per month fee, and each individual patient gets whatever they need. So this is part of a transition in how we look at Medicare and Medicaid, and how the whole payment system in the state happens. I mean, possibly the end vision of this is that our hospital service area just gets one budget number and we divide it up any way we see fit, as long as everyone gets the health care they need. So this is, it's part of a much larger change that's coming.
Next question is asking for a further explanation of the 3-day requirement that led to the waiver. So currently, Medicare requires patients to have a 3-day inpatient stay prior to going to a skilled nursing facility. This law was created in the early 60s and was initially created, interestingly enough, because there were high costs of care within skilled nursing facilities. And so a decision at that time was made that that cost should be transferred to the hospital. When the law initially came into being, it was supposed to be a 5-day inpatient stay. And the American Academy of Family Practice Physicians said, whoa, these patients don't need a 5-day stay. So they grappled and ended up with a 3-day stay. So that's the history behind the requirement, and that's one of the reasons why there's this waiver program in place, because for a lot of patients, the 3-day stay does not make sense. It's not what the patient needs. It's not the right place for the patient to get their care. What applicable patients need in this circumstance is rehabilitative care. They need daily services of a physical therapist, and a skilled nursing facility can be a much better place for that patient to receive care than inside a hospital. Yes?
Yeah.
The question is about if this particular patient's an attributed patient with Blue Cross Blue Shield, and someone were to say, oh, she's attributed, she counts for the 3-day stay, but she really doesn't because she's not part of the waiver, what happens to that cost? Is that a good summary?
Well,
And then Medicare
you waive it
insurance.
as OneCare, but Blue Cross Blue Shield doesn't waive
Right,
it.
it's for secondary.
So I wouldn't get my supplemental
So
payment.
I'll try to answer that question, and if that doesn't help, let me know and we'll go back. So in order for the logistics of making this work to determine if a patient is eligible for that 3-day inpatient stay to be waived, there are many double checks across the system. Our care management team checks the list of attributed patients to make sure that they qualify. Again, for the waiver, they have to have Medicare or Medicaid, so that's the first level of checking. In addition, the social worker, the admitting staff at the skilled nursing facility is also checking the list of attributed patients to make sure that that patient qualifies. So there's a checks and balance system to make sure that the patient is actually eligible and able to have that 3-day stay waived. Does that help answer the question? No.
No.
So I really feel like the question, and correct me if I'm wrong, is really about the Blue Cross and Blue Shield
Exactly.
piece, your
Supplemental
secondary,
kicks in.
your secondary insurance.
I wanna know if
Okay,
the
so-
supplemental kicks in.
So the supplemental in a SNF stay typically kicks in at day 21. Medicare covers 100% for the first 20 days. At day 21, they go 80% Medicare, 20% supplemental, and that supplemental can either be private pay or a Blue Cross and Blue Shield insurance. So if Blue Cross, and this is my interpretation of it, and I think this will require more information and more research because I think that's a really valid point, is once you hit day 21, it's quite possible that Blue Cross and Blue Shield will not pick up that bill for that 20%, which can amount to approximately $150 a day
If you hadn't stayed the 3 days.
if you haven't stayed for the 3 days. So I think it's a really, really awesome question. It's one that hasn't come up before, so we will definitely research that. So the questions that we were unable to answer, meaning that we are just not qualified to answer them in a way that we feel comfortable with, that will make sense. We want to make sure that we get you the best answer that we possibly can. So we will bring the questions back and answer them, have other people from OneCare answer them. What we would ask of you is that if your question wasn't answered, or if you have additional questions, please write them down and maybe include your phone number or your email address so that we can then get back in touch with you.
So thank you all very much for coming this evening. Thank you for your interest and your engagement. Thank you for your really excellent questions. Like I said, it took a lot of brain power, and we've got more work to do because you asked some really great questions. So to close, to remind you at the beginning of the session, I said that our goal was to help explain what an accountable care organization is and what it means for you as an individual, what it means for our community, and what it means for our hospital. So I'd like to close with what we think is kind of the most simple answer to that complicated question, and that is an accountable care organization and is geared at creating the best care possible for individuals, the best care possible for the population, and working to lower costs for you as a patient, working to lower costs for a healthcare system. Any final questions or closing thoughts here tonight? Well, thank you all so much for being here, really appreciate it, and we will work to answer those remaining questions and send a group email with those answers. Thank you.